Pardon?
The long lecture.
It shouldn't be. Okay. Thank you very much. All right. So good morning, class. So today we're looking at drugs that affect the digestive tract. Drugs that affect the digestive tract. The digestive tract is also, we're having a lecture now. The digestive tract is also known as the gastrointestinal tract. So you hear the GIT, and that also refers to the digestive tract. So when I said the digestive tract, I'm sure you're very familiar with the digestive tract from primary and onto, human biology that you did in first year. So can you tell me which parts of the body make up the digestive tract? Which parts of the body make up the digestive tract? Or the gastrointestinal tract? The oral cavity, the esophagus, stomach, pharynx. Okay, good. So we're well aware of the parts of the body that make up the digestive tract. So it's very important that we know what we're talking about. So we're going to be looking at the content for this lecture. We look at the drugs that affect the digestive tract, which of course invariably means we're looking at the diseases or the conditions that affect the organs or those parts of the body. All right? So if we're looking at the drugs that affect the digestive tract, we're looking at conditions that are unfavorable to those parts of the digestive tract. So those conditions, the drugs, it will be drugs for dyspepsia and peptic ulcer, for constipation, diarrhea, spastic colon, ulcerative colitis, and Crohn's disease, as well as that is wrong. Anal fissures and hemorrhoids. So that should be an FISS, not a features like that. All right. So those are the conditions that we'll be looking at and the drugs to treat those conditions. So the learning objectives would be what we have here, like we usually do at the end of this class. Can I talk about the different conditions? Can I mention what they are and the drugs that I use for them? The mechanism of action of those drugs. So that's what we need to be able to do at the end of this class. So we already mentioned the digestive tract starts from the mouth, the oral cavity, straight through to the anus. Okay, so the digestive tract, from what we can see, what can we say about the functions? So it starts from the mouth and right through to the anus. What are the functions of the digestive tract? Pardon? Absorption of nutrients. One. Of enzymes. Okay. Waste elimination from the body. Good. So absorption of nutrients. Absorption of nutrients, waste elimination, secretion of enzymes. Okay. So the digestive tract functions to help with first the food needs to go into the mouth. All right. So with the consumption of food, mastication in the mouth, then you have digestion in the stomach, more digestion in the small intestine, and then absorption, all right, and then secretion of gastric juices in the stomach, Alright? And then we have the large intestine, where you have waste elimination occurring. Alright? So that's the function of the digestive system as it is. So what is the process of digestion? How does digestion occur?
First, you put your food in the mouth.
And where?
And you chew. Then the sleep is in the borders.
Then it goes to?
Yeah, all this one, then it goes down. Yeah, it moves down your esophagus, yes, and then, yeah. Get on.
Yep. Thank you very much. Someone else take it from there.
What?
Yeah, it goes down the esophagus, then right?
And then you want to specifically say that purpose.
And then the fun destination.
You know the system.
Yeah, it enters the stomach. Gastric juices are released, I think. And then they form chyme.
So the formed chyme already. What else happens to chyme? Today? Okay, so we just formed chyme. Where did we form chyme now? In the stomach. Where do we go to from the stomach? We go to the small intestine. And then what happens in the small intestine? So there's further digestion and there's absorption in the small intestine. So before we get to the large intestine, the colon, rectum, and then we have whatever is not useful to the body, we pass that as waste in the. So we have the so the food that we eat at the end of the day does not come out like you eating banana now, and then you go to the bathroom and you see banana falling out from the other end. No, it doesn't happen because of all these processes. So we have this gastric juices that help to make the food more soluble and break it down to smaller molecules that the body can absorb. So the body can absorb nutrients from that through the small villi or the small intestine. And this is what is useful to the body at the end of the day. So we gastric juices. So gastric juices are very, very important. So what this means is that in the absence of gastric juices, what will happen to your banana? It probably will come out the same. In the absence of gastric juices, yes. So gastric juices and gastric juices are also referred to as gastric acid. Alright? Because it contains a lot of hydrochloric acid. Alright? It has a lot of hydrochloric acid, pepsin, and some other substances that help with the breakdown of food, particularly the proteins to polypeptides that can be digested. So it breaks down food generally. So that's the function of gastric juices. Alright. So this gastric acid, as it is very useful in digestion, it can also have a negative impact on the body. Alright? So when we talk about diseases that affect the digestive system, the gastric acid or juices play a very important role in those conditions, particularly when we talk about dyspepsia and peptic ulcer or your gastroesophageal reflux disease. All of those ones, gastric acid play a very, very important role in the presentation of those conditions. And we already know that gastric acid contains a lot of hydrochloric acid because that is what helps with the breakdown of the food particles that we eat. So what is dyspepsia?
Indigestion.
That's another name for dyspepsia, which means indigestion. Okay, so it the symptoms will be abdominal pain, heartburn, nausea, and vomiting. So it's another name for heartburn as well. So dyspepsia is similar, synonym for heartburn. Sometimes when people feel that, they say they have heartburn as well. So indigestion indigestion would be what now? Why would there be indigestion? Where would indigestion occur?
I think if there is no enzymes necessary
To
break
break
down
down
the food.
indigestion can occur. Or if the motility, gastric motility is reduced and it's slower than usual, then it slows down the rate of digestion. Alright, so but dyspepsia can be organic or non-organic. Means it can be as a result of an ulcer, or it could be non-ulcer in origin. So when you have that condition, it could be either caused because you have an ulcer-like presentation in the GIT, or it could be even in the absence of ulcer. So you have your organic causes being peptic ulcer, esophageal reflux, your GORD, or even cancers of the intestine or the bowel can lead to this dyspepsia, which is a feeling of discomfort or pain in the upper abdomen or chest, a burning pain in the upper abdomen or chest, all right, or discomfort in that part of the body is referred to as dyspepsia. So if it is not caused as a result of the presence of an ulcer or a carcinoma or your GERD, it would be as a result of, if it's that, so it is non-ulcer in origin, it is organic in origin. If it is non-ulcer, then it will be because of your psychosomatic factors or irritable bowel syndrome, all right, or it could be gastritis, or because the person is having some lifestyle or environmental factors like smoking, drugs, and all of those things that can lead to dyspepsia. So dyspepsia is basically discomfort or pain in the upper abdomen or the chest, all right, or which can be described as burning. All right. So if a person has dyspepsia or even ulcer, to identify the cause of the ulcer, what needs to be done is called an endoscopy. All right. An endoscopy is the diagnostic procedure that is used to determine if a patient has an ulcer based on the symptoms that they are presenting with. Then we want to confirm, is it really an ulcer that this patient has? And then we do an endoscopy. I think we get very familiar with it when you put something into the tummy to see what the mucosa area is like. If there is any ulcer or any break in the mucosa lining of the GIT, and that would be a confirmation for ulcer. So that's that for dyspepsia. It is a discomfort or pain in the upper abdomen or chest area, all right, that appears as burning or gnawing, and can lead to a feeling of fullness in the patient. So we saw what dyspepsia is. Now let's look at what peptic ulcer is. So we already identified that the stomach, when we eat our food, we need gastric juices for it to be digested. So gastric juices, the stomach secretes about 2.5 liters of gastric juices every day, all right? So it means it is for every day, as long as we eat, we need these gastric juices to keep, to digest the food. So as soon as, sometimes just the smell of food, the presence of food, we know what happens with salivation when you see someone eating, when you smell food. All of this can trigger the release of juices. So we already identified the presence of gastric juices. How are those gastric juices released in the GIT? So they are secreted by certain cells in the GIT. The gastric juices are secreted by certain cells of the GIT, and these cells are referred to your chief or peptic cells or your parietal or ozontic cells. So you have these two different kinds of cells that are involved in the release of gastric juices. And your peptic cells release your prorenin and pepsinogen, while your parietal cells release or secrete your hydrochloric acid and some intrinsic factors. Alright? So your parietal cells are, we said that gastric juices are mainly made up of hydrochloric acid, and that's what gives it the acidic component. So the parietal cells release the hydrochloric acid by a proton pump system. Okay? A proton pump system known as your potassium hydrogen ATPase system. So it's a bit complex to give off hydrogen somewhere, get chlorine somewhere, but we're not going to go into that. Just know that there is a proton pump that is involved in the secretion of hydrochloric acid by the parietal cells. Alright? The parietal cells use a proton pump system to release hydrochloric acid. Do we get that? So, we've been talking about mediators and chemical mediators and neurotransmitters. For the parietal cells to release hydrochloric acid by this proton pump, they need a mediator. Okay? And one of the mediators that is very prominent in mediating the action of the release of hydrochloric acid by the proton pump is histamine. So there are other mediators, but histamine is very, very prominent when it comes to this aspect of releasing hydrochloric acid through the parietal cells. Then we also have acetylcholine, we have gastrin also involved as mediators. Now we're very familiar with mediators, I'm sure. Mediators that mediates this secretory activity. So let's go over it again. Your parietal cells or ozontic cells secrete hydrochloric acid by a proton pump action. Alright? That proton pump action that releases hydrochloric acid is mediated by histamine, acetylcholine, and gastrin, majorly. Alright? Histamine, acetylcholine, and gastrin majorly. So you have another hormone in the body called somatostatin, which inhibits the action of parietal cell. Alright? It inhibits the action of parietal cell. But that is by the way. So when we're looking at our NSAIDs, we talked about the cytoprotective nature of the GIT. That nature has found a way to protect the stomach from the hydrochloric acid that is needed, or from the gastric acid that is needed for digestion of food. But nature has a way of protecting itself by the formation of mucus gel over the gastric mucosa. Do you remember that when we were doing our NSAIDs? Alright. And so we saw, while we were looking at NSAIDs, that prostaglandins that are formed from the action of cyclooxygenase enzyme on arachidonic acid have a role to play in the formation of this, or in the cytoprotection of the GIT. Do we remember that? Okay, so that still comes to 4 here. So in the GIT, there are mucus-secreting cells in the mucosa itself. In the GIT mucosa itself, there are mucus-secreting cells. So prostaglandin E1 and E2 rather, and I2 are responsible. They function for cytoprotection. They also can inhibit the acid production to help protect the stomach. So they function for cytoprotection and they can inhibit gastric acids. So I said when we were looking at NSAIDs that there are different types of prostaglandins that are produced. Remember, so you see PGE1, PGE2, 1, 2, 1, 3, 1, 4, E3. So there are different types, and each of them has a function. So you have this prostaglandin that inhibits acid production, and then you have this prostaglandin that functions to protect the GIT mucosa by stimulating mucus and bicarbonate secretion. Okay? So they want the functions for cytoprotection of the GIT, stimulate mucus and bicarbonate secretion, and also help blood flow circulation around the GIT mucosa. Alright, so that even if there's any injury, they supply the area with enough blood so that the healing can take place quickly. Remember why inflammatory process, you need blood supply for healing to occur. So they ensure that there is enough dilute mucosal blood cells that healing can occur. So what is the role of your bicarbonate? Bicarbonate ions are trapped in the mucus to form a gel to protect the mucosal surface. Alright, I think I'm losing something there. Let me see. Okay, so bicarbonate acid gets trapped. So bicarbonate acid is the production of bicarbonate acid is stimulated by prostaglandins as well. So all of these are present, are available in the GIT when during that process. So it creates a gel-like protective barrier that maintains the mucosal surface at that pH to prevent the acids from causing harm to the mucosal surface. So alcohol and bile can disrupt this mucosal protection. So someone who is an alcoholic, all right, or increased bile production can cause disruption of that mucosal protection that we just talked about. Okay. So basically, what it means that for a patient to develop peptic ulcer, what needs to happen? So we've seen two factors here now. We have a protective factor and we have an aggressive, or protective factors and aggressive factors. Do you understand? So we have the factors that are protecting the tummy and the factor that can cause harm to the tummy, to the mucosal lining. All right? Can we identify these different factors? The mucosal damaging factors will be your aggressive factors. The gastric acid is the main player when it comes to that. Gastric acid is the main player. Anything else? We mentioned some other things now. Alcohol. We said alcohol can break that barrier. Remember, we just saw that alcohol can break that barrier. Stress would also be an aggressive factor that would break that barrier, that natural barrier of the GIT mucosa. So those are your aggressive or mucosal damaging factors. Your protecting factors.
How would stress break
I can't give you the pathway physiology. I don't know. Stress-induced ulcers. Have you heard of it?
Yes.
Yeah. So patients, people can develop ulcers as a result of stress. It induces increased acid production. Okay, so those are, we already identified our aggressive factors. Our protective factors would be our, what now? Protective factors that are protecting GIT, prostaglandins, the mucus gel, the bicarbonate, all right? And also we see nitric oxide as one of the protective factors, or mucosal protective factors. So what would happen? And then another thing we didn't mention is your non-steroidal anti-inflammatory drugs. Which factor would it be? Aggressive or protective? Aggressive or protective? Aggressive. What does not NSAID do? When you take NSAIDs, what happens? You inhibit, if you take your traditional NSAIDs, you inhibit prostaglandin production, which then you lose the cytoprotection. So NSAID is one of those aggressive factors. Okay? Anything that induces an ulcer is an aggressive or mucosal damaging factor.
But is that like a definite, like, isn't it possible?
Yes, it's possible. Especially if it's taken for a long time. Okay? If it's taken for a long time, and the dose as well, in high doses, it's very, very possible. What's the content of grandpa? Okay, so tell me. Answer the question. Okay, then. Paracetamol and aspirin. Does it fall on there? Paracetamol is not NSAID.
No, I'm saying aspirin is NSAID, paracetamol is an
Yes, but because of the aspirin too. That's why we need to be careful with grandpa. Alright, so we've so for peptic ulcer to develop, there needs to be so the body has a way of balancing out this factors. You're aggressive and you're protective. You have a question. You're disrupting me. Ask me. Alright, so the body has a way of balancing out the aggressive and the protective factors. You understand? But if there is a tip in the balance, alright, if the aggressive, so usually the protective factors should either balance out or be more than the aggressive factors. If it tips, the aggressive factors above and the protective factors are lower, then the possibility of developing an ulcer is very, very high in such cases, alright? The possibility of developing an ulcer is as a result of an imbalance between your protective factors and your aggressive factors. Alright, so the peptic ulcer, the symptoms of peptic ulcer will be, remember that dyspepsia would arise either because there is a peptic ulcer, it is organic in origin. So the dyspepsia will be one of the symptoms of peptic ulcer. Am I making sense? We said dyspepsia can be organic in the presence of dyspepsia is organic in the presence of peptic ulcer or your gastroesophageal reflux disease. Remember, so heartburn and indigestion, those also will be part of the symptoms of peptic ulcer. Am I making sense to you? If dyspepsia occurs because of the presence of an ulcer, then it's going to be a symptom of ulcer. Am I making sense to you? Okay. So symptoms: dull pain in the stomach, weight loss, not wanting to eat, nausea, vomiting, easily feeling full, heartburn. All of those are symptoms of peptic ulcer. Sorry, are symptoms of peptic ulcer.
I wish to be a little bit clarified on peptic ulcers and gastric ulcers.
So peptic ulcers can either be duodenal or gastric, depending on the location in the stomach, in the GIT rather. So it could be either in the stomach or in the duodenal. Where is the duodenal?
I don't understand.
So there are a few differences to clarify between both of them. It has to do with if it is in the stomach, do you feel pain? It's just very slight differences. Do you feel pain? Some people feel, depending on the location, you feel pain when you are eating. Okay, when a person is hungry, you feel pain. Some will feel pain after they're eating.
Or when they're hungry.
Yeah, when you are eating, when you're hungry, you feel pain. Some, the pain will come after they're eating, depending on the location or the ulcer. With the duodenal ulcer, you have one would wake you up at night. You have midnight pain. All right. So those are the slight differences, very slight differences between. So basically it's about the location of the ulcer in the GI. That's what differentiates the two. And that is attached to the symptom the patient feels as well. Okay. So we've seen the symptoms. So here is imbalance between your gastrointestinal mucosal protective factors and aggressive factors then will lead to an ulcer. Aggressive factors are here, defense forces are there, and the associated diseases that can arise as a result of peptic ulcer are also indicated here. So which are the drugs we use for dyspepsia and peptic ulcer? The first drug or class of drugs we're looking at are called antacids. So antacids are chemical formulations, okay, that are used for the relief of acidity. So if a patient has hyperacidity, you can use antacids for such patients. So they are safe and easy to use, all right? And they are quite effective, but all they do is to neutralize. So their mechanism of action is neutralization of acid. So they are prepared to be able to neutralize acid. And once the acid is neutralized, the patient feels the relief because the burning and the pain and all of that would be taken away at such time. So you have antacids. Antacids can either be magnesium based or aluminum based or sodium bicarbonate or calcium containing products, and each of them has its pros and cons. All right, for your magnesium based antacids, they would usually cause diarrhea, while your aluminum based antacids will cause constipation. Sodium bicarbonate products would increase the blood pressure if the patient is already hypertensive because of the formation of sodium chloride during the neutralization process. So sodium chloride is formed. You know what sodium chloride is? Your normal salt. So that increases the blood pressure of persons who are already hypertensive. Calcium containing products will cause, so you use it to neutralize the acid. But once the acid is neutralized, it can cause a rebound acidity, which means it can cause the acid levels to increase again. All right, that's what's called by rebound or acid rebound. Because of how to use your antacids, antacids should be used 30 minutes after meals and at bedtime. Okay, 30 minutes after meals and at bedtime. Why is it used 30 minutes after meals? To avoid gas. Yes, it works for that. Particularly after meals, why don't you use it after a meal? When is the gastric acid released? Is it before the meal or after the meal? Before. Gastric acid. Is it released after the meal or after you've eaten and before you've eaten? Before, during, and after. That's when you do this. Okay. But you want to take your antacid 30 minutes after you have eaten. Right? So if it's released before, when is the most quantity going to be released? During the meal. So if when the thing that needs to work out is there, that's when you have more of the release. So that's why it's usually after the meal. So you have present at the release of your acids. All right.
And another reason why it might be taken after is because if you take it before, then the acids won't digest.
Absorption. All right. Also because of drug interactions. So DI means drug interactions. Because of drug interactions, you want to use antacids 2 hours before you take any other meal. So you advise your patients if you have to take any other, not other meals, any other drugs. Antacids have, they interact with many other drugs. So you take it 2 hours before the consumption or administration of any other drug, especially your tetracyclines, iron, and the goxin, those particular ones. You already know the mechanism of action, right? So antacids, we saw they can be aluminum, magnesium, sodium bicarbonate, calcium, but they can come in combination as well. So you can have aluminum and magnesium being combined, in which case they will neutralize their side effect. One is diarrhea and the other is constipation. When you have them together, so they have the side effect is reduced in that case. Some other things that are added to antacids are, one of them, dimethicone or simethicone is added as antiflatulence. What's flatulence?
Gas.
Having gas, okay? Yeah, that's having gas. So this one's help to disperse the gas and help you to easily get it out of the system. Dicyclomine is also added to antacids as an antispasmodic, because with peptic ulcer you find spasmic activity. Your peristalsis, spasms are generated in peptic ulcer as well. So that will help like that with that. Then you have oxetazane as your local anesthetic. What would it do? To help with pain, okay, to numb the pain in particular places. And then anti-regurgitant is your alginic acid. It's added to some products to help to ensure or to relieve the reflux action that occurs in your GERD, your reflux esophagitis. So you see more of this on table 16.1 in your textbook. So these are the antacid combinations that can be added to your antacid preparations. So it has been found that in peptic ulcer there is a bacterial implication. So it's not just about an imbalance in the mucosa-protective and aggressive factors. There is an organism that has been implicated in peptic ulcer, and that organism, that bacteria, is known as your Helicobacter pylori. Okay? Helicobacter pylori is the bacteria that is implicated in duodenal or gastric ulcers. Alright? And this organism would only be identified, you cannot tell, if someone has peptic ulcer now, if someone has and they present with symptoms, we said earlier, the only way to really confirm peptic ulcer, aside the symptoms, is to do an endoscopy. So if there is a bacterial implication, we cannot tell from the symptoms. So we need to do a test, a series of tests. Confirmation is through either they will use the stool of the patient and try to see if the bacterial antigen or byproduct is there, or they'll ask the patient to breathe into some test materials, or they can take a biopsy of the GIT mucosa to check to see if the bacteria is present there. So to treat, once this is confirmed, and the treatment of the elimination of Helicobacter pylori is not done empirically. So you don't just see someone who has peptic ulcer and say, oh no, you must be placed on treatment for elimination of Helicobacter pylori. There needs to be a confirmation done before you can place the person on the treatment. Or if it happens that, sometimes what happens is that the patient has been on anti-ulcer medication, but the ulcer keeps relapsing. It keeps relapsing, then you want to do a test to see if Helicobacter pylori is present, and then place the patient on medication. So sometimes when you have this relapsing ulcer, it could be because of this bacterial presence. So to eradicate Helicobacter pylori, you do a treatment regimen for 7 days with a proton pump inhibitor and 2 other antibiotics, either your clarithromycin or metronidazole or amoxicillin. is used for the treatment. Amoxicillin can be replaced by metronidazole, all right, in the presence of clarithromycin can be replaced by amoxicillin in the presence of what? In which instances do you want to replace amoxicillin? Allergy, in allergy or resistant situations. All right. Also, some resistance has been identified for metronidazole as well. So you need to check to see if the strain of Helicobacter pylori is not resistant to metronidazole before you use metronidazole. So we saw here that you can use a proton pump inhibitor plus 2 of the following antibiotics to eradicate Helicobacter pylori, all right, in patients that have been confirmed to have Helicobacter pylori. So what are proton pump inhibitors? They are a class of peptic ulcer drugs, all right? Proton pump inhibitors are a class of peptic ulcer drugs. And what is their mechanism of action? If you remember, the refresher there, if you remember when we looked at how gastric acid is secreted in the stomach, all right? You remember, we said your parietal cells secrete hydrochloric acid and some interesting factors by proton pump, and the process is mediated by histamine. Okay, so they secrete hydrochloric acid by that proton pump activity, the exchange of ions. So if we want to stop the production of hydrochloric acid, can we target the proton pump? Yes. So we can target the proton pump. So that is where we got this class of drugs from, proton pump inhibitors. Is it making sense to you? Mm-hmm. So this class of drugs is gotten from by antagonizing the hydrochloric acid production from the parietal cells. Are we together? So if we can inhibit the activity of the proton pump, then hydrochloric acid will not be released. Okay? Hydrochloric acid will not be released. So your proton pump inhibitors will stop the proton pump from exchange of the ions that occur to help us form the hydrochloric acid. So they are very, very potent inhibitors of gastric acid secretion, but they are usually used short term for peptic ulcer disease and also for the treatment and prevention of your gastroesophageal esophageal reflux disease, or if it is an NSAID associated erosion. So if a patient has peptic ulcer as a result of the use of non-steroidal anti-inflammatory agents, then you can use your proton pump inhibitors. Examples of your proton pump inhibitors are omeprazole, lansoprazole, and esomeprazole, and all the prazoles that you see there. The common side effects of these ones are diarrhea, constipation, and the other things that you see on the slide. So, do we get the reason where we get that class of drugs from? Let's make sure we keep it. It's to inhibit the proton pump activity that releases hydrochloric acid from the parietal cells. All right. Another class of drugs that is used in the treatment of peptic ulcer or in the management of peptic ulcer is your H2 receptor antagonist. The H2 receptor antagonist. H2 receptor antagonist also came about as a result of trying to inhibit the process of hydrochloric acid production in the normal process of hydrochloric acid production in individuals that have your hyperacidity. And that is the histamine function. We said the release of hydrochloric acid by the proton pump, okay, is mediated by histamine. So if we can inhibit histamine, All right, so you get it. If we stop histamine, we can stop the release of hydrochloric acid as well. So your H2 receptor antagonist, histamine would need to bind to the H2 receptor for it to mediate the release of hydrochloric acid through the proton pump in the parietal cells. If your H2 receptor antagonist would sit on the receptor, prevent histamine from binding to the receptor, then we will stop the release or secretion of hydrochloric acid. So the mechanism of action is reduces gastric acid and pepsin secretion by blocking the action of histamine at the H2 receptors in the parietal cells of the stomach. Is that clear? Okay, so all of this comes from the activity of the parietal cells in secreting hydrochloric acid. So everything that is helping the parietal cell to secrete hydrochloric acid, we are trying to block them. And if we block it, then our patient will be relieved. Okay, so examples of your H2 receptor antagonists are cimetidine and ranitidine. Those are very common examples. But with H2 receptor antagonists, you do not get, the patient does not feel like with warfarin, that it takes 3 days for you to, for the onset of action, for you to feel relief. H2 antagonists also, you will not, the patient will not get symptomatic relief until about a week after commencement of administration. So it's the onset of action is delayed. So you need to use antacids along with your H2 receptor antagonist to cover the patient for that time before the drug starts acting. Am I making sense?
So you mean?
So if you start taking it today, the patient will not feel the relief, will not feel, the symptoms will not be better, all the heartburn, the pain and all of that will not be better as a result of your H2, your cimetidine or your ranitidine. So you give an antacid to help the patient, to relieve the patient's symptoms until the drug begins to act. Remember with warfarin, we said, what do we give? We give heparin concomitantly until warfarin can start acting in 3 days. Remember? So it's the same situation. You give something else until what you actually want to act starts acting.
So you mean it together and then
Yes, together. You give concomitantly. So you give, because if you wait, you're just extending the time for it to start acting. If you give it today, like in 7 days time, you can start seeing the effect. So before that time, you give an antacid in addition to that, on that as well. So your cimetidine has, let me see, lansoprazole, omeprazole. Did we see drug interactions with lansoprazole and omeprazole? Short-term anti-proton. Okay, so your ranitidine and cimetidine has very large drug interactions with other drugs. Okay, it interacts a lot with other drugs because it suppresses, it has an effect on the liver enzymes, your hepatic microsomal enzymes. Okay, it inhibits them, so it interacts with a lot of drugs. So it is taken with caution when you need to use it with other drugs. Also, it causes cimetidine causes gynecomastia, which is an enlargement of the mammary glands, and so it's not really used for young men. In men, the use is usually not very well received because of the enlargement of the mammary glands in such patients. But ranitidine has less drug interaction because it doesn't have that inhibit the liver enzymes like cimetidine does, and it doesn't cross the blood-brain barrier, so it has less CNS effects. So when we're also doing NSAIDs, I talked about misoprostol. Misoprostol was one of the drugs I mentioned that can be used in addition with your non-steroidal anti-inflammatory agents to prevent the development of ulcer, or if an ulcer patient needs to use an NSAID, then you give them along with misoprostol. Misoprostol is a prostaglandin analog, all right? Is a prostaglandin analog. So if it is taken, which is taken orally, and then it can help to induce the cytoprotective activity of prostaglandin, which is absent in your once you take NSAIDs inhibit cytoprotection, remember, except it's your selective NSAID. Your traditional NSAID inhibits the prostaglandin that causes or that functions for cytoprotection. But when you use misoprostol can elicit that cytoprotection in the patient.
I've seen misoprostol administered to patients who had termination of pregnancy. How does that help?
Remember the functions of prostaglandin. What did we say prostaglandin does in uterine contraction? Huh?
But if it's a prostaglandin analog, it's an antagonist, so it blocks all.
No, it's not an attack. An analog is similar. We have
Similar.
yeah. So we saw. Remember that there are different kinds of prostaglandins, and they all have their different functions. So you have prostaglandin that functions for uterine contraction, induces uterine contraction, and that's why misoprostol is that particular kind of prostaglandin that induces uterine contraction. That's why it's given to induce labor, okay? It will induce uterine contractions, or it can be used for premature abortions because it induces uterine contraction. So it's contraindicated in pregnant women. If a woman is pregnant and she needs to use an ulcer drug, definitely misoprostol is not the drug of choice for a pregnant woman. All right.
Sorry, ma'am, I didn't understand that.
Okay.
So you say
We said earlier when we did NSAIDs, when we looked at prostaglandins, we said there are different kinds of prostaglandins and they have different functions. And we saw one of the functions of prostaglandin is that it induces uterine contraction. We also saw prostaglandin functions for cytoprotection. It induces or stimulates the secretion of mucus and bicarbonate to form the mucus gel that protects the GIT. So we have our prostaglandin GE2 and I2 that function for that, E2 and I2 for cytoprotection in the GIT. Alright, then we have the prostaglandins that will form, what's the other one? Cytoprotection and uterine. Prostaglandin can also cause uterine contraction. So if you use prostaglandin, where are we now? We are in peptic ulcer. If you give it in pregnancy, misoprostol is a prostaglandin analog. It functions, it's a synthetic prostaglandin. Do you understand? Like you have your opioids now, you have the natural ones, the endogenous opioids that are formed in the body. Then we have opioids that we get from the opium plants. They both have the same function, isn't it? Analgesic, isn't it? Remember your opioids. So, misoprostol is a synthetic prostaglandin that manufactures your endogenous prostaglandin that causes cytoprotection and uterine contraction. So when you give it to the patient to induce cytoprotection, remember it also has a downside depending on the circumstance of causing uterine contraction. So if you give it to a pregnant woman, you induce
but in that case, just need to give it to people at termination of pregnancy.
Yes. The basic thing you need it to do, what it does is to induce contraction.
That's why you give it.
That's why when I want to whatever premature abortions use it. Just because they're not using it to protect their GIC. It's just to induce uterine contraction. Okay? It's just to induce the uterine contraction. That's what they are interested in. It will give cytoprotection, but that's not what they want. What they want is the uterine contraction. So it depends on what you want from it.
So now for females that are like overdue and they want to induce, like, will they give that?
You can do that as well. if they do insertions, they just insert it in. If they want to induce labor, they insert it into the vagina. Okay, so we've seen that now. So prostaglandin analogs will function like prostaglandin, give cytoprotection in the case of peptic ulcer, and in the other case we're talking about as well. Other drugs that are used in peptic ulcer and gastroesophageal reflux disease are, one of them is domperidone and metoclopramide. These ones help the GIT and the gastric emptying. That's the peristaltic movement of the GIT, all right? Gastric emptying, the peristaltic movement of the GIT. It helps to increase that, all right? So it helps to increase that, but you don't want to increase the peristaltic movement of the GIT, except all the other drugs have been tried. Antacids have been tried, your proton pump has been tried, and your H2 receptors have been tried, and they're not working. That's when you want to use these drugs that facilitates gastric emptying, increase gastric tone for to reduce the feeling of fullness that the patient has. Another class of drugs are called your cytoprotective drugs, all right? And your sulforaphate and bismuth subcitrate fall into this group of cytoprotective drugs. So they form a protective layer on the damaged tissue in the GIT. They form a protective layer or a paste in the case of sulforaphate on the GIT, so that the acid is protected from acidic activity or contact. Okay, they form a layer at the base of the ulcer to protect it from acid contact. So that is that for these two. So they are called cytoprotective drugs. Sulforaphate and bismuth subcitrate will fall under your cytoprotective drugs because they form a layer, a coating on the ulcer in the GIT. Do we get it? Alright, so those two. So another class of drugs that affects the GIT. So we said the GIT functions for absorption, there's gas release and all of that. Another condition that affects the GIT is constipation. Okay, so we said the GIT functions for waste removal, isn't it? It functions for waste removal. And if the GIT cannot eliminate waste as it should, and the fecal matter is sitting in the large intestine and it's not coming out, how comfortable is that? Has anybody ever had constipation? How comfortable is that condition? Very, very uncomfortable. It's very, very uncomfortable. Alright, so laxatives are the drugs that are used for.
When people say they feel like it is the feces is there, but they feel like it's not going through the right place, it's hitting by the wall, where some take spoons and help it get out. It is there, but it's not taking spoons. See the anus there, the whole there, where it's supposed to go out. It's not coming out there. They feel it's already out, it's supposed to be, but it's not hitting where it's supposed to hit. Not by the wall. So it's not part of constipation or something else.
Constipation.
She understands.
Okay. It's just what?
I say it's you are only like the feces or it's to go out now it's stuck there. That's constipation.
So that's constipation. Okay. Let's leave the spoon alone. Let's continue with the class. All right. So that is once if the feces is not coming out, as it's the individual is not passing the feces as regularly as they used to, then they are constipated. It's relative. It's not as regular as they used to. Some people pass 3 times a day, and that is their normal. If someone who does 3 times a day is now doing no day, or none at all, or every 3 days, then they are constipated. And when a person is constipated, you have the piling up. That's where you have the fecal matter being larger than normal, and then it's difficult. And then the reabsorption of water also causes the hardness of the feces. And also with constipation is a reduction in motility, intestinal motility. The peristaltic movement that should push it out is not as it should be. So it's difficult for it to come out as well. So there is the dehydration, reabsorption of water is higher than normal. Alright? So you have so it's the delayed passage of feces through the bowel, and this can be caused by either because the individual is not eating enough dietary fiber, all right, and not taking enough fluid intake also is below what is necessary, all right. Pregnancy can also induce constipation, especially in the 3rd trimester, when the baby is sitting. Not diarrhea. No, just constipation. Diarrhea will be an infection. Constipation is a normal thing you find in pregnancy. Alright. All the drugs, some drugs that the patient take, and I'm sure we are aware of some of those drugs we talked about in the past, in our previous classes. Opioids, iron, okay? All of those will cause constipation. Antidepressants. We talked about antacids today. Which of them causes constipation? Aluminium. Is it aluminium antacid that causes constipation? Magnesium causes diarrhea. Alright. Old age. Okay. The reduced GIT tone can lead to constipation. Lack of exercise, sedentary lifestyle can lead to constipation. Hypothyroidism, or sometimes lesions in the bowel would also cause constipation.
Also, when the individual doesn't go to the bathroom,
yes, not responding to the urge also can cause constipation, particularly in children. In children, because they don't want to go, they don't want to go and sit on the potty, they just have this inhibition or the other. So they keep it, and then it causes constipation. Because once it is kept there is reabsorption of fluid, and it just gets harder and harder. So the drugs that I use for constipation, I think, okay, I don't need to do slideshow here. Are your bulk forming laxatives, your stimulant laxatives, or your osmotic laxatives? Alright? I think I have another one. There's another one. Let me see. Your enemas are there somewhere. Okay. So you have your bulk forming laxatives. Okay, these ones increase the mass of the bulk forming laxative, increase the mass of the bowel, the mass of the food in the bowel, and so because the mass is increased, it increases peristaltic activity. All right, it increases peristaltic activity because of the increased mass, and because they are fiber, they absorb water. They absorb water instead of water loss that had been occurring. They absorb water, and so cause the feces to swell and soften. Those are your bulk forming laxatives, and examples are ispagular, your pus, and methyl-cellulose and seculium are examples of bulk forming laxatives. So when a patient is using a bulk forming laxative, they need to take a lot of fluid, because you need a lot of fluid to help it soften the stool. And also the action is in 12 to 72 hours. It's not contraindicated in pregnancy, so it can be used by pregnant women. The second one is a stimulant or contact laxative. This one directly stimulates the colonic nerves. All right, they work on the colonic, directly stimulate colonic nerves, and so they should be used with caution because they can have dependence.
Question. Okay, in my household, when you're using laxative, they say you're supposed to drink like tea. To
Where?
make it
Where?
go for like.
Who said so?
Black families are
Black families are like, when you're drinking laxative, you're supposed to drink like tea. I don't know how
See,
does
the
that.
whole day, but you can be drinking black tea.
You drink black tea and then it starts working. Not like liquids, but black tea.
Do you have to use? Are you going to you would use the laxative and then you use the black tea in addition?
No, you drink laxative with water and then you just drink black tea after.
What is black tea?
You make tea.
Oh, tea without milk.
Yes.
Oh, it's just the fluids that we need, eh?
Yeah.
But why?
I think it's just warm fluids that we need.
It's warm. So it's just the warm fluid.
That's what I'm asking.
Why not
Why is there black tea?
I don't know. I should ask you. I should ask you. But the idea is just, you see, because I think people find it, so black tea without, you put sugar.
Yes, you do put sugar. I like to my mom likes to put in sugar. She just says I mustn't eat anything.
Just
They
black
eat
tea.
something.
Yeah, black tea.
They
You're
eat
supposed to
something
eat it.
called black tea.
No, we don't. We just drink
So you make
Black
black
tea.
tea is just your Lipton, just without milk. So I think it's just because it might not be very palatable just drinking water. So rather than drink water, just drink tea. I'm thinking that might just be it, eh? Just to mask the water and make it more interesting. Put some sugar. Okay. So this one's the stimulant or contact laxatives stimulates the colonic nerves. So they work on the physiology of the GIT. So they need to be used with caution because dependency can develop to their use, and they're only used when no other solution has worked. Senacot and Bisacodil are examples of your stimulant or contact laxatives. And they are not used in pregnancy. Also, they are used as slimming aid. All right. So they are only used for a short time and second line of treatment. They also can cause dehydration because of the stimulant activity that they have. So another class is your osmotic laxatives. This one retain fluid in the bowel. Your lactulose, macrogels, and all of that are examples. Stool softeners are also referred to as enemas. This one you can pump through the rectum. Okay, you can pass it through the rectum. You have your sodium phosphate isotonic saline solution or soft soap solution. You know your enemas. They pump through the anus too. Sometimes they're used prior to surgeries or procedures to clean the bowel before those procedures are done. So those are your laxatives. You have your stimulant laxative, your bulk forming laxative, and your osmotic laxatives. And what they basically do is to either stimulate peristalsis, like your stimulant ones, or increase fluid content in the fecal matter to soften it. Okay? Your bulk forming ones will absorb. Your the last one, what are they called now? Osmotic ones will retain the water. Okay, so after looking at constipation, the next condition we want to look at is diarrhea. So diarrhea, unlike constipation is also increased. No, unlike constipation is reduced. Alright? Diarrhea is when there is an increase, okay, of stooling. Not just an increase relative to the person's normal. Alright? If someone goes to the toilet every 3 times a day, then they are not having, if that is their normal, it's not diarrhea. But for someone who goes once and they're going 3 times, then it is now diarrhea for them, especially if there is increased volume and fluid content. If it's more watery, loose stool. So if it is watery, loose stool, and there is frequency in the passage of such stools, then it becomes diarrhea. Most times it's usually caused by, it can be caused by food, bacteria, virus, or toxins and all of that. So it can be acute or it can be chronic. Okay? Diarrhea can be acute or, what did she say?
Menstruation.
Yes, sometimes diarrhea precedes menstruation. Yes, I agree with that because I also do experience it at times. So menstruation also can. Okay, so you have, but it's very slight, very short. Then we have, so it can be acute or it can be chronic. It can be acute or chronic. If it's acute, it's usually self-limiting, as in you don't have to use any medication. It can stop by itself without medication. But when a patient has diarrhea, the thing to know with diarrhea is that it's the loss in body fluid and electrolytes. So when a patient has diarrhea, it's not just about drinking water. You can drink water to replace the fluid, but you need to replace the electrolyte that is being lost because the body, your excretory system, passes out electrolytes with the fluid. Okay? So it's not just about the fluid, but the patient needs to be aware that they need to replace the electrolyte. So that is the important thing about diarrhea. Especially when it comes to children and the elderly. Children and the elderly, they get dehydrated very quickly. You see a baby passes stool 3 times and then they become lifeless and weak and inactive. So for them, we need to make sure that they are rehydrated, not just with water, but with fluid and electrolyte replacement. And that is done. So most times your acute diarrhea is caused by a virus, and your fluid replacement can be done using your oral rehydration solutions, which you can get from the pharmacy. Or in the absence of that, you guys know how to prepare the SSS. Advise the mother to prepare the SSS and administer to the patient. So diarrhea, when an individual has diarrhea, an adult or a child, for 24 hours, especially if it's a viral-induced diarrhea, they are advised not to use any medication but just the fluid and electrolyte replacement. No medication for the first 24 hours. For an adult, after 24 hours, if it doesn't stop, then they can be given medication. But for a child, you keep giving your fluid and electrolyte replacement therapy. So, medication is not advocated for children when they present with viral-induced diarrhea. And the rotavirus is one. Have you done immunization? Have you done immunization? Not yet. Okay, so rotavirus is one virus that usually causes diarrhea in children, in infants. So they have a vaccine that they get to prevent or to reduce the incidence of rotavirus infection. So what can be used to relieve symptoms is what's called an adsorbent. These medications absorb the organism. That is, if it's a virus, when they take them, your missed kaolin, pectin, all right? Locally, I heard of charcoal. Has anybody had that experience? When charcoal was given to someone who has diarrhea? Activated charcoal. You heard of activated charcoal. Have you heard of anything like that? Your grandmother, your grandmother? No stories about it. For poison, no, you can give for diarrhea sometimes too, just to absorb. So what do? They just absorb the invading organism or substance. Catch it on. Okay. So if the patient has, so loperamide is not advised within the first 24 hours because if it's a viral-induced diarrhea, you want the patient to keep passing the feces to flush out the virus. If they keep passing the stool, they would eventually flush out the virus. But if you give loperamide reduces gastric motility. It reduces the frequency of the stool. And so the patient retains the virus in the system and the virus keeps causing a problem. So that's why for 24 hours you don't want to give any medication. And your SSS, I'm sure you know how to prepare that. If it's caused by bacteria, it would also clear up in 3 to 4 days. Okay, it also will clear in 3 to 4 days, but you need to keep giving the fluid and electrolytes during that time, and no antimicrobials, except if that bacterial infection has been confirmed to be caused by those organisms there. The exceptions, your Shigella, cholera, dysentery, cholera, salmonella, and amoebic dysentery. If it is any of those organisms that cause the bacterial diarrhea, then you give antimicrobials. Okay? Then you give antimicrobials. And your antimicrobials that are used are listed just underneath. Or you go to table 16.8. The chronic diarrhea is usually associated with some other underlying condition. Alright? And one of the most common causes of chronic diarrhea will be diarrhea that lasts for more than 2 weeks. One of the common causes is HIV infection, all right? HIV infection, giardiasis, or if there is a problem with the bowel, like your spastic colon, your irritable bowel syndrome, and those other kinds of conditions. How do you treat chronic diarrhea? You can give loperamide, increase dietary intake, give the symptoms that comes with the chronic diarrhea, the pain and all of the, try and treat the symptoms. Antispasmodic for pain and abdominal distension. If dehydration is very severe, the patient can get an IV fluid to replace dehydration. And for HIV patients, usually HIV patients that have chronic diarrhea are placed on cotrimoxazole treatment to help with the diarrhea. Okay, so we saw here anti-diarrhea drugs. The one that we saw was loperamide now. So drugs that reduce bowel motility to treat diarrhea are called your antipropulsants. And you have your loperamide, the phenoxylate, and your codeine phosphate. All of those are opioid drugs. Okay? All of them are opioid drugs, and we know opioids cause constipation. Alright? So that is why they are used for diarrhea. Then, the other conditions that we are looking at are spastic colon, which is your irritable bowel syndrome, and also your ulcerative colitis and Crohn's disease. And the characteristics of each of those are listed in this table. So this table presents some other conditions that affect the GIT. If you look at your contents, they are the last two. Your spastic colon, which is your irritable bowel syndrome, IBS, or the ulcerative colitis and Crohn's disease. Your IBS presents with early morning. It has a fluctuation between diarrhea and constipation. The patient will have diarrhea for some time, and then the patient will be constipated after some time. That is your irritable bowel syndrome. So, and also the patient will present with abdominal pain, and it can be caused by tension. Most times you can't find the reason why the patient has this irritable bowel syndrome, and it's more common in women than in men. So you have somebody who wakes up very early in the morning, they're having early morning diarrhea this week, next week they're having constipation. That fluctuation is irritable bowel syndrome. Then your treatment for that, so you treat the symptoms. Okay, so they have pain and distension, you give them an anticholinergic, propylene, antispasmodic for the spasm they will feel. For the diarrhea, you give the loperamide to stop diarrhea. If they have constipation, then you give them. So it's a symptomatic treatment that you give to this patient. Remember that most times you don't know the reason why they're presenting with this condition. Your ulcerative colitis and Crohn's disease have to do with inflammation of the GIT, okay, of the mucosa of the intestinal tract. and both of them I explained there. For ulcerative colitis, it's usually the colon that is affected, all right? The colon is affected and it is presents as chronic diarrhea, rectal bleeding or abdominal pain. Crohn's disease can affect any part of the GIT or the intestinal tract, but more often also the distal small intestine or colon is inflamed, and it also presents with chronic diarrhea and that. The treatment is symptomatic. Here, for your Crohn's disease and ulcerative colitis, we use your glucocorticoids. Remember our corticosteroids? We said they also have anti-inflammatory activity. So one of the diseases or conditions we use them for is your ulcerative colitis or Crohn's disease. Other drugs that I use are indicated there. Methotrexate is one of the drugs that is used for Crohn's disease. Some of this, drugs for anal fissures and hemorrhoids. This is where the anal part of the anal sphincter is affected. So anal fissures will be when you have cracks in the anus. That is called your anal fissures. Hemorrhoids will be the extension of the veins, so extrusion and extension of the veins. Usually comes with constipation. Okay. Hemorrhoids you see to be like varicose veins, as in
Just where the anus.
in the anus.
Inside.
Outside. Pushes out. The treatment is to increase fiber intake, and if such person, because it's usually associated with constipation, so such individuals should avoid drugs that cause constipation, because it will just make the situation worse. Because it actually comes when the patient has constipation and you're pushing to pass, like what she was talking about now. You're pushing so hard to pass the feces that you push out the veins of the anal sphincter. So, then laxative. Another thing with laxative that I didn't mention is that laxative I use for the treatment of what? Constipation, isn't it? Laxatives themselves can cause, excessive use of laxatives cause constipation. Excessive use of laxatives can lead to constipation. That's one other thing we need to. Sometimes what happens is that because the patient uses the laxative and they pass the stool, because the laxatives clean out the colon and they clean it out nicely, such that it's so empty that the patient doesn't have to pass stool for another 3 to 4 days because it's empty. So they now think they're constipated and then they reuse the laxative again. And they reuse the laxative. That's another abuse of laxatives. Okay, so if there is itching with the hemorrhoids, you can cleanse with water, apply subgallate ointment. So a patient that has hemorrhoids, do you know what suppositories are? Those ones that you put in the anus. Yes, the rectal preparations. So those ones are used for hemorrhoids as well. Lactulose can be taken to relieve constipation as well. So pain before, so because if a patient that has hemorrhoids, actually it's very painful to use to defecate, but you can relieve pain with local anesthetic gel applied to the hemorrhoids before defecation. So I think that is the end of today's lecture. I'll see you next week. Any questions?